As you know, many of our faculty get invited to a variety of places. This is a lecture that Dr. Cocanour was asked to give as the POT lecture at Western Surgical just this last year. We are pleased to have her share that experience with us. This is not a completely esoteric talk for all of us as well, because we deal a lot with the issue of informed consent. Often people are potentially uncomfortable with consenting for a procedure they don't know about, and we don't want you to be put in that position. And there's a lot to think about when you think about informed consent. So our head of the ICU trauma ACS faculty, senior faculty member, Chris Cocanour. Thank you.
Thanks. Let's see. Now, this is one where I did give it this spring at Southwestern Surgical and trying to come up with an idea of what to talk about. And I think this is something that touches every single one of us. I have no disclosures. Okay. It's an ethical concept that's codified in law, but it's in daily practice at every single healthcare institution throughout the world. And what I'm going to talk about today is what is informed consent, some of the ethical foundations of informed consent, as well as some of the legal history of informed consent, as well as how we can improve that consent process. What I'm not going to talk about today is research consent. That can be a totally separate topic, and I wanted to confine it to how we use it clinically, because I think there's a lot of things that we don't necessarily realize as I went back through and started reading a lot about informed consent. The Merriam-Webster definition is consent to surgery by a patient or to participation in a medical experiment by a subject after achieving an understanding of what is involved. Interestingly, the term informed consent was not used until 1957, so this is a relatively recent idea. A better definition, though, is probably the underlying process by which the treating healthcare provider discloses appropriate information to a competent patient so that the patient may make a voluntary choice to accept or refuse that treatment. There are three fundamental criteria for consent. The patient must be competent, which means that they have to be able to communicate choices, understand and assess the information that was given. They have to understand the consequences of that decision. They have to be adequately informed. That means they have to know, at least at minimum, if the diagnosis is known, the diagnosis, the procedure, any alternatives to that procedure, as well as benefits and risks. And they must not be coerced. And it's the physician's responsibility to obtain informed consent. You have to assess the patient's ability to understand relevant medical information and implications of treatment alternatives, and to make an independent, voluntary decision. There's basic information that must be there for informed consent: the diagnosis, the nature and purpose of recommended interventions, the burdens, risks, expected benefits of all options, not just the single procedure that you're going to talk about, but the alternatives, including not doing any procedure at all. You have to document the informed consent conversation and the patient's decision in the medical record in addition to the written consent. And if you have any conflicts of interest, and that would be like if you work for a medical device company or a drug company, you have to disclose that to the patient. And this comes from the AMA and the California Hospital Association. Federal mandates for what's needed on the form includes the name, the signature of the patient or their legal representative, a name of hospital, the name of procedure, name of all practitioners performing the procedure, risks, benefits, alternative procedures and their risks, the date, time of consent, and a statement that the procedure was explained to the patient. Additional things that can be helpful, including the signature of the person who was witnessing the consent, as well as the name and signature of the person who actually explained the procedure. Interesting, this is from 2000, and Bottrell et al. Looked at 157 hospitals and their consents. only 26% of those forms included all of the basic elements. And remember, the basic elements are a description of the procedure, the benefits, the risks, the alternatives. When do you need an informed consent? And it varies a little bit with state to state, hospital to hospital, and what their mandates are. But it's influenced by the clinician, the hospital, as well as interpretation of the professional and specialty group recommendations. Joint Commission sets a standard that hospitals must establish and follow policies that describe which procedures or care, treatment, or services require informed consent, because there is a simple versus complicated. Simple is for things that are simple and common. Examples would be blood work, x-rays. Usually these are included for a hospitalized patient in the hospital consent. Informed consent are for those procedures that are deemed complicated. An oral consent is for treatment and procedures that are at low risk. Again, these are administration of drugs or vaccines, labs, routine x-rays. But meaningful discussion is still needed to let the person know that this is why you are having XYZ. A written consent is required for procedures that produce significant pain or discomfort, produce pain or discomfort that requires sedation, anesthesia, or narcotic analgesia, significant risk of complication or morbidity, require injections into a joint space or body cavity, as well as a very long list of procedures. The VA actually has a very comprehensive consent policy. Next question is, how much information is considered adequate? How many potential risks must be described? How many alternatives? You could be there all day if you had to do every single alternative. And there are 3 proposed standards that have been brought up over the years. Professional practice standard is what a reasonable physician would give as far as the information. Unfortunately, this is often inadequate. The typical physician will tell very little. There's also the reasonable person standard. What would a reasonable person expect to want to know? And then there's the subjective standard. And what would this particular patient need to know and understand to make an informed decision? This is the most challenging to incorporate into practice, as it requires tailoring information to each patient. The scope of the physician's communications to the patient must be measured by the patient's need, and that need is whatever information is material to the decision. We're starting to get into a little bit of legalese, which you're going to see further in the talk. And CMS interpretive guidelines have some of these information, but material risks in CMS terms are considered to be a risk that is a high degree of likelihood, but a low degree of severity. Or a very low degree of likelihood, but high degree of severity. So if you could potentially die from this procedure, then even though it is a very unlikely occurrence, then you would need to put that in as a risk. Hospitals are free to delegate to the physician who uses the available clinical evidence as informed by their professional judgment, the determination of which material risks, benefits, and alternatives will be discussed with the patient. So we have some leeway. But these are the things you have to keep in mind when you're thinking of what are the material risks. Physician needs not to inform a patient about a treatment that cannot legally be administered in California. You have to inform a patient about alternative treatments only to the extent that it's required for competent practice within the medical community. So, for example, you don't have to discuss a coffee enema with a patient as a potential alternative treatment. There are exceptions to informed consent. There's 5. A public health emergency, medical emergency, patient waiver, therapeutic privilege, or incompetent patient. Public health emergency, environmental health interventions, think having good water quality. Interventions to combat contagious disease. We saw this with people that were coming back after having been exposed to Ebola. They would be placed into quarantine, sometimes without their consent. Public health information reporting or use, for example, reporting of contagious disease. The emergency treatment exception, the provider reasonably believes that a medical procedure should be undertaken immediately, and there is insufficient time to obtain the consent of the patient or the surrogate. This is implied consent. The law implies that if the patient were able, consent would be given. The medical emergency exists when you have immediate services are required for the alleviation of severe pain, immediate diagnosis and treatment of unforeseeable medical conditions are required if such conditions would lead to a serious disability or death, if not immediately diagnosed or treated. But if you have a medical emergency, only the emergency condition may be treated. If the patient or surrogate have refused treatment and the emergency condition arises from this refusal, the emergency treatment exception does not apply. For example, if a patient who is a Jehovah's Witness has refused blood and they have continued to bleed and now get to a point where they have, they're now immediately dying from this, that is not something that would be covered under this, because what they had previously refused is what's causing the current event.
Except in children.
Okay. Except in children. And there are so many different things, but that is where the child didn't necessarily refuse. That's where the patient refused. Not the patient refused, but the patient's mother or father refused. And so that's when it gets into. I could go on. You could have a whole course on informed consent. So I'm trying to touch some of the highlights, but Dr. Farmer brought up a really good point. There are lots of different things that go into this. I want to talk about the common misconception of the two-person consent. If two doctors agree that a patient would benefit from procedure, the two doctors consent on behalf of the patient, no matter whether the patient had capacity to make healthcare decisions or not. There is no federal law that permits this, so this does not exist. There's no legal requirement for a physician to consult a second physician to confirm the existence of emergency. Now, it may be that you have a hospital or medical staff policy that requires that you get a second physician to say, yes, indeed, this is an emergency. But having to require two physicians to do a consent does not exist. You have to document in the medical record that an emergency exists when you have an emergency. And for example, the immediate treatment of the patient is necessary because XYZ, whether it's because they had a gunshot wound and they now have altered mental status and they can't give you a consent. But you have to document why you consider it an emergency. There's a third exemption to informed consent is a patient waiver. Patient may request not to be informed, and they may delegate the decision-making to the physician or to a surrogate. This obviously has a lot of potential for abuse. The voluntary waiver after suggestion can easily become a non-voluntary waiver after intimidation. So this is not something that you want to do, but if it happens, you have to disclose information. You need to document that in the chart. There's also therapeutic privilege, where the physician is not required to disclose information to the patient if such disclosure would seriously harm rather than benefit the patient. Somebody who totally freaks out about what they and just can't consider whatever it is, and you really feel that it may seriously harm the patient's mental status, etc. But again, this has a high degree of potential for abuse, as it conflicts with the patient's right to know and their ability to decline treatment. Again, you have to document the facts and circumstances that led to the decision not to give all of the information to the competent patient, and what information was actually given to the patient, as well as any discussion with the patient's designated surrogate. And then we have the incompetent patient, which we oftentimes see, and we're going to see more and more. This is when the patient has any condition or a treatment that affects their cognition that may impair decision-making capacity. And these include things like the neurodegenerative diseases like Alzheimer's or Parkinson's, traumatic brain injury, psychiatric illness, cognitive aging, or delirium. We get into, you always hear the competence and capacity. And some authors will actually use these interchangeably by design, but competence is considered a legal term. and all adults are presumed to be competent unless they're determined by a court to be incompetent. Capacity is actually a clinical term, and it's task-specific. So Moy and Marson illustrated 8 examples of civil capacity. So something like independent living would require a broad scope of abilities and skills, includes both cognitive and procedural skills to be able to live alone. However, treatment consent is narrow, and it's primarily a cognitive task. So someone who may not be able to live independently can still give consent for a procedure. You have to make a valid treatment decision. You have to recognize that there is a decision to be made, understand the needed information, understand the treatment options, understand the consequences of each option, the risks, burdens, and benefits, and be able to rationally manipulate that information to come up with a decision consistent with the patient's values. In looking at decision-making ability, it can be broken into 4 areas. Understanding, where the patient can state the meaning of the relevant information. What's the diagnosis? What are the risks and benefits, indications and options? They can express a choice. They can state a decision. Now, if you have a patient that continually goes back and forth between saying, yes, I want the procedure, no, I don't want the procedure, yes, I want the procedure, no, I don't want the procedure, that may reflect an inability to express a choice. They may not be able to make a decision. So that patient may actually lack capacity to give a consent. They have to be able to appreciate the ability to explain how that information applies to oneself. And reasoning, ability to compare information and infer consequences of the choice. For example, somebody who has a hernia, their reasoning is that they have to be able to appreciate that they have a hernia. They have to be able to state what the cause or their diagnosis and what the risk benefits of either having it repaired or not having it repaired, and appreciate how it would apply to themselves, and to be able to say, gee, this is, if I have it done, this will do this. If I don't have it done, this will. So they'll infer the consequences of that choice. Let's switch over now to looking at what some of the ethical foundations of informed consent have been. And it's basically rooted in 3 of the ethical principles: beneficence, respect for autonomy, and justice. Beneficence, promoting the patient's welfare, do or promote good. Respect for autonomy, persons should be free to choose and act without controlling constraints imposed by others. And injustice, where this is mainly, you think of it more in terms of in research, where a just distribution of the burden of risks of research in participation in society. Beneficence, as we know, was rooted in the Hippocratic oath, first do no harm. The Corpus Hippocraticum was a collection of around 60 medical texts that came from what was purported to be the Hippocratic schools. And in all of those, it fails to mention patient permission. And in fact, some of the comments were including things like concealing most things from the patient while you are attending to him, turning his attention away from what is being done to him, revealing nothing of the patient's future or present condition. So obviously, beneficence was what it was based on. Going ahead to the Middle Ages, Henry de Monville was a French physician, and who, again, rooted in the Hippocratic beneficence model, further compounded by the Christian model, which again promoted beneficence, exhorted his colleagues to promise a cure to every patient, but tell parents or friends if there is any danger. And also justified lying to the patient for maintenance of hope. The maintenance of hope would justify the deception. For example, if the canon was sick, tell him that his bishop has just died, so that the hope of succeeding him will quicken his recovery. He also recommended not to take a case where the patient violently refuses a medical intervention. A patient who's screaming and fighting is unlikely to enhance the physician's good reputation. Going on to the 1700s, Benjamin Rush was a signer of the Declaration of Independence. He had a classical learning background, was, as you'll see, was taught by at the University of Edinburgh. He felt that really should share information with patients, but not so much to allow them to make a decision, not for their autonomy, but to understand and help be motivated to comply with whatever the physician's recommendations were. He got this from John Gregory, who was his teacher. He was a professor of medicine at the University of Edinburgh and was influenced by Francis Bacon. And he realized the need to educate the patient and public. But again, he viewed the role of physician in the traditional terms of beneficence, but with openness and honesty. Thomas Percival published a treatise on medical ethics in 1803. He was influenced very much by the Reverend Thomas Gisborne, who absolutely opposed lying to patients. However, he struggled with this concept because the medical ethics in that was mainly medical etiquette, and it promoted gentlemanlike behavior. And it was, if you lied to patients, then that would make you less of a gentleman, but the role of the physician was thought to be the minister of hope and comfort, so you still needed to basically lie to the patient to make them feel better. Again, trying to give them hope when there may not be hope. American medicine, the AMA, came out with their first code of medical ethics in 1847, and this was mainly based on Percival's medical ethics. Interestingly, a passage by John Bell regarding truthfulness. Veracity, so requisite in all relations of life, is a jewel of inestimable value in medical description and narrative. Yet it wasn't in the section where describing the interaction of physicians with patients. It was in the section regarding the interaction between physicians. Worthington Hooker was a Connecticut physician who published what is considered one of the best ethics papers on physician and patient. And this was after the first AMA medical ethics came out, and he denounced lying and deception in medicine. He also criticized physicians for deceiving patients, doing unnecessary services, and studying the science of patient getting, to the neglect, to some extent at least, of the science of patient curing. In the early 1900s, physicians at that time were more concerned about the interactions between physicians. Beneficence still remained the main principle underlying interaction with patients, but autonomy was just beginning to glimmer. Remember, you had the Flexner Report in 1910. So we now go into more the legal foundations of informed consent, and it's interpreted and grounded in respect for autonomy. Now you're starting to hear the word autonomy come in. Case law is more directed towards rights and duties to protect the patient's right to self-determination. It's mainly rooted in battery and negligence. Battery is considered the intentional touching of a person in a harmful or offensive manner without their consent. This would be a medical procedure that's done without having a consent. A provider exceeds the scope of the consent or procedure for which the consent is not obtained. And even if that procedure is done to aid the patient, it's performed competently and has no adverse outcome, you're still at risk for being charged with battery. Negligence has 5 elements. Duty to give information to the patient. Physician breaches that duty. Injury to the patient that's financially measurable. An injury is due to an undisclosed or possible outcome. And had the patient been informed of that outcome, a reasonable person would not have consented. There are 4 cases that are considered the basis of informed consent. Most of these were in the early 1900s. In the 1800s, there were a few cases, but nothing that really rose to the top, that really changed how we did things. Moore versus Williams, patient had given consent to operate on the right ear, but then the physician decided, oh, it would be better for me to operate on the left ear. And this one ruled in favor of the patient. when you enter into a contract to operate to the extent of the consent given, but no further. Pratt versus Davis in 1906 did not obtain a consent for hysterectomy, and it limited implied consent to emergencies and when patient knows the consequences of allowing the physician to exercise professional judgment. Rollator versus Strain in 1913 gave consent to drain a foot infection, but not to remove any bone. She expressly said, do not remove any bone. The operation was performed, bone was taken out, and operation was not performed as to how it was agreed to be. And this decision strengthened the patient's control. Schlellendorf versus Society of New York Hospitals in 1914 is probably the one case that you'll hear the most about. Patient consented to an abdominal exploration, but no operation. But the physician, when he did the exploration, decided to take out the fibroid anyway, and she sued. Cardozo's opinion is one of the classic opinions that you'll see. Every human being of adult years and sound mind has a right to determine what shall be done with his own body, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages. This was the first glimmer of patient's right to self-determination. Nothing really happened much over the next 40 years until 1957. Remember when I said the term informed consent came into being was in 1957? This goes to Salgo versus Leland, Stanford Junior University Board of Trustees. You can guess where that occurred. Permanent paralysis as a result of a translumbar aortography. The patient was not told of the possibility of paralysis. And it was decided that the physicians had a duty to disclose any facts which are necessary to form the basis of an intelligent consent by the patient to proposed treatment. So it requires the disclosure of risks and alternatives. It gave physicians discretion on what should be disclosed, but this is where the term informed consent comes from. Nathanson versus Klein, the patient was not told that cobalt radiation could cause burns, and it was first to ground the physician's informed consent liability in negligence rather than battery. And if the injury results from a known risk that is not disclosed to the patient, the physician may be liable. Professional discretion versus the patient's right of self-determination. Canterbury versus Spence was 1972, was disclosure of a person's reasonable standard rather than professional standard. Again, going back to those standards of information given. Cobbs versus Grant, Wilkinson versus Vesey, all three were in 1972. And whether to proceed with therapy requires reference to the values of the patient and thus are not exclusively medical determinations. In Cobbs versus, and what a physician knows or should know is his patient's position and would attach to the disclosed risks in deciding whether to submit or not to surgery. Material information came from Truman versus Thomas. She refused a pap smear, and then later died of cervical cancer. Her family sued, and because she was not given the risks of not having the pap smear. And so this further clarified what material, remember going back to what we talked about early on, as a fact that is not commonly appreciated. The physician must apprise the patient of risk of not undergoing treatment. And if the physician knows or should know of a patient's unique concern or lack of familiarity with medical procedures, this may expand what they need to tell the patient. So you have to gauge it on what the patient needs to know, going into a more subjective standard. Keep in mind those early 70s had a lot going on, and I just kind of put some of these things here. You had Secretariat winning the Triple Crown. You had impeachment. You had war in the Middle East. You also had the American Hospital Association and the Patient's Bill of Rights. So it was after the 60s you saw a lot more about individual rights. There was also a malpractice crisis. There were increasing numbers of malpractice cases and increasing sizes of awards, skyrocketing insurance premiums. At that point, state legislators enacted informed consent laws. 25 states between 1975 and 1977 put into place informed consent laws. But now we have those are present in all 50 states. But it was a way of trying to tamp down some of the malpractice cases. 2017, the consent process. Communication issues are the most frequent root cause of serious adverse events reported to the Joint Commission, whether it's wrong site surgery or operative or post-operative complications. And this is just a very good quote by George Bernard Shaw. The single biggest problem with communication is the illusion that it has taken place. Probably very apt for consent. There's a lot of barriers to understanding when you're trying to present information and to get what we think is an appropriate consent. There's ineffective provider to patient communication, whether it's because we speak different languages, health literacy, cultural issues, lack of a shared decision-making model. These are all things that can put barriers in between what we may tell the patient to what they're actually hearing. Cooper et al. Did a look at communication about the intensity of surgical treatment. They found that there were different areas, whether it was in the patient or with the surrogate or surgeon or system, whether all of these would factor in as to how much and provide difficulty in communication. I would definitely recommend reading her paper. Limited English proficiency. The federal government actually requires interpretation and translation services. The culturally and linguistically appropriate services in healthcare class is a national standard from the Department of Health and Human Services, and it requires language assistance regardless of the size of language group in the community and at all points of contact and during all hours of operation. Limited English proficiency, you cannot require a patient to bring an interpreter. Interpreters must be qualified, and you can't rely on a minor child except in an emergency situation. And you may rely on an accompanying adult if requested by the patient and the person agrees, but it's going to be best to document in the medical record that a qualified interpreter was offered, because friends and family may not be able to interpret accurately. They may have inadequate knowledge of your anatomy, of physiology, or just because of the stress of the situation, they may not be able to actually put into the appropriate words that you need the patient to understand. There's also cultural issues that come into being. It may be that the decision maker is designated by the group. A signature on a piece of paper as opposed to verbal may actually convey a lack of trust. So they may not want to sign a piece of paper because it's affecting that trust in that person. Illegal immigrants may fear deportation by putting a name on a paper. And in some Asian communities, a shaman or other person must be consulted to be able to obtain consent. Again, it's a process to obtain a consent. It's not just getting a signature on a form. And so ideally, you want to have a clear written policy. The procedures that require written consent, the professional roles in the informed consent process. Hospital employees are not supposed to obtain consent. Use of qualified medical interpreters, the role of patient surrogates, the timing of informed consent, the nature of a complete informed consent process, and documentation and verification. How can we do it better? We can provide formal training to physicians on an effective provider-patient communication and decision-making. The impact on informed consent and patient safety can be a lot. Simplify the content, length, and language of documents and the patient materials. Implement policy and interventions that for patients that may have limited hearing or visual or limited English. We want to make available appropriate communication tools and materials and to provide shared decision-making tools between the patients and providers. And for physicians, we provide communication models to better evaluate patient understanding and conversations to address miscommunications. There's been 3 different models of providing information to patients. A paternalistic model, which is rooted in beneficence, the doctor knows best. The informative model, which came out of the 1970s in the Patient's Bill of Rights, where the information was given, the patient or the family was expected to make the decision. And then the interpretive or shared decision-making model, which is now coming into what is considered to be probably the best model. Shared decision-making is where you inform the patient about the medical condition, but you clarify the patient's understanding of diagnosis, the prognosis, and expectations for recovery, not just throwing them a bunch of words. You identify the patient's priorities and their goals, and you determine the health states that the patient would find unacceptable. Are they willing to be left in a nursing home, or what are their expectations for recovery? What do they deem acceptable? And then you affirm your commitment to the patient's well-being. And it accepts individual self-determination as a desirable goal. So if that patient decides they don't want the treatment, that should be acceptable. The problem is that informed consent, the risk disclosure is discrete complications, assumes the patient has brought into a post-op aggressive care. Alternatives appear secondary rather than a real choice, but it satisfies the legal requirements. And with this, you have potential outcomes that may be unwanted aggressive treatments, post-operative stress, and conflict that occurs between surgeons and the patients and families. As we heard earlier this year from Dr. Schwartz when she gave grand rounds, the best case, worst case framework is a good way of being able to help provide better understanding of the patient's diagnosis, disease, and potential alternatives. And ideally, you give the different alternatives, and you give a best case, worst case for each one of those alternatives. And then, given what you know about the patient's underlying disease history, their other medical problems, you give them an idea of where they may land on that best case, worst case scenario. And it gives them something that they can actually look at and refer to when discussing with their family. You want to be able to tell a story to the patient so that they can get a better understanding of what might be involved with whatever the procedure. And this is on YouTube, and I would wholeheartedly recommend just reviewing it. It gives an example of how to use the best case, worst case, and tool in a whiteboard demonstration. And the pattern of conversation has started to change. The old, where you link the problem to a surgical solution. So you have XYZ problem, this is what we're going to do to make it better. New is a choice between what the valid alternatives are. This is where what we have. These are different things that we can do for it. This is the most likely outcome. So we have to decide which path to take. And a lot of that depends on your sense of where the patient's been and where they want to go. You focus on, used to be you would focus just on the risks and benefits. XY, you have this risk, and is probably about XY%. There is a risk of this much percentage of death with whatever the procedure is. Whereas now you talk about what the outcomes. Under the best circumstances, you're going to be out of the hospital in 2 weeks. But in the worst, you may have complications from surgery that will put you in the hospital for months, and then you would die. Trust is something that has to be inevitably part of the consent process. And it's something that we have to absolutely safeguard, because it's a prerequisite of having the patient do what you need them to do. They have to trust that you have their best interest. And many times it's that developing that bond of trust that allows us to be able to have them go ahead and say, yes, I'm willing to have you do this procedure. And we have to realize that it's very wrong to jeopardize that trust. So, in closing, it's more than an informed consent, it's more than just a signature on a legal document. It's a process of communication, and it shows the trust between a patient and physician. Thank you.